Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club is hosted jointly by the AST Thoracic and Critical Care and Transplant Pharmacy Communities of Practice. Before we begin, I have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. Please note that your lines have all been muted so that only the presenters can be heard for the recording. If you have a question for our panelists during the Journal Club, please use the Questions tab in the GoToWebinar panel to participate. If there are questions we do not have time for, we will either answer them individually offline, or we will post them with the answer on the website following the Journal Club. Please be aware, if you click the X icon in the upper right corner of the main GoToWebinar panel, you will close and exit the webinar. As noted, this Journal Club is being recorded. The archive will be available within 24 to 48 hours after the session. Finally, when you log off at the conclusion of today's Journal Club, you will see a short survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to Dr. Douglas Jennings from Columbia University to begin our presentation.
Welcome everyone, and thank you so much for joining us today. We have two excellent clinicians on the panel to discuss this article. We have Sudhir Kushwaha, who is a professor of medicine and was recently appointed as the medical director of heart transplantation and mechanical circulatory support within the Department of Cardiovascular Diseases at the Mayo Clinic. And we have Richard Daly, who is a professor of surgery and also serves as the surgical director for heart and lung transplantation within the Department of Cardiovascular Surgery, also at the Mayo Clinic. And so without further ado, I'm going to turn it over to the presenters to discuss the effects of mTOR inhibitor-related proteinuria on progression of cardiac allograft vasculopathy and outcomes among heart transplant recipients.
Okay, well, this is Rocky Daly. I'm the presenter, and I'll provide some information on this topic and this article today. The article was published online in the American Journal of Transplantation in June of 2020. As you heard, our moderator is Dr. Doug Jennings, who's an associate professor of pharmacy and assistant professor of nursing at New York Presbyterian Hospital and Columbia University. And of course, this has been a preeminent center in heart transplantation for many years. Again, I'm Rocky Daly. I'll provide some background and then present some information from this article. The discussant is my colleague, Dr. Sudhir Kushwaha, who is the senior author on this paper and has really been the primary driver of conversion, routine conversion from calcineurin inhibitors to sirolimus at our institution. We're in flyover country in Rochester, and compared to New York. At the Mayo Clinic, our city has only a population of about 100,000. Well, mTOR inhibitors include drugs like everolimus and sirolimus. And as I mentioned, we have a routine protocol of conversion from calcineurin inhibitors, cyclosporin or tacrolimus, to sirolimus at 3 to 6 months after heart transplantation. So why are we talking about this? Well, there's been a motivation for a while to consider sirolimus as a primary immunosuppressant in order to avoid the renal toxicity related to cyclosporin or tacrolimus. But it also turns out that there is reduction in progression of coronary allograft vasculopathy and a decreased risk of malignancy among patients that have been converted. And there is an association of improved survival in the papers I'll show you, although these are not randomized trials. So the conversion, though, from a calcineurin inhibitor to sirolimus is associated with proteinuria in some patients. And the question this paper asks is, among the patients that develop proteinuria, is that a marker for more progression of allograft vasculopathy or poorer survival? Sirolimus is rapamycin, and rapamycin was identified in a Streptomyces species in a soil sample from the island of Rapa Nui, which is Easter Island, in 1972. It was a remarkable compound in that it had antibacterial, antifungal, and anti-proliferative effects, and also is immunosuppressive in that it inhibits antigen-induced T and B cell proliferation and antibody formation. It acts by inhibiting binding the target that it binds to, which is just called the target of rapamycin, the mammalian or the mechanistic target of rapamycin. mTOR is a protein kinase. And don't worry, I'm a surgeon, so I'm not going to go through a lot of this in detail, but normally mTOR binds to a binding protein, and that activates it to stimulate one of two pathways. The complex becomes mTORC1 or mTORC2 to stimulate these pathways. Sirolimus or everolimus inhibits the binding of the binding protein and prevents the activation of these pathways. What are they? Well, mTORC2 pathway controls lipid and glucose metabolism, among other things. And the mTORC1 pathway stimulates cell growth, proliferation, motility, survival, and a lot of activities of just cell life, including cytokine signaling, which stimulates lymphocyte growth and differentiation and stimulates T and B cell activation. So sirolimus or rapamycin will inhibit cell proliferation, and as shown in this porcine coronary artery model that has had endothelial injury from a balloon, it inhibits intimal hyperplasia. This is data from the ISHLT showing use of various immunosuppressive agents over different eras. And internationally, the mTOR inhibitors are still used relatively sparingly compared to now tacrolimus, the predominant calcineurin inhibitor. So these are 4 papers from our institution. You'll see Dr. Kushwaha is the senior author, and all of them show benefits of conversion to sirolimus. We're looking at cardiac allograft vasculopathy, which is quantitated in our data with an intravascular ultrasound at the time of coronary angiography. So what we're seeing here is lumen area and plaque area and vessel area. These can be converted to volume, plaque volume, vessel volume, by incorporating the segment length being analyzed. So in this paper from a couple of years ago, we looked at progression of cardiac allograft vasculopathy using IVUS in patients who have been converted to sirolimus and compared to patients that remained on a calcineurin inhibitor over time. And you see that plaque volume progresses considerably more in patients who remain on the calcineurin inhibitor, as does plaque index, compared to patients who are converted to sirolimus. In fact, among the patients converted to sirolimus, there is very little progression of plaque over time. And in the same paper, the patients that were converted to sirolimus had less all-cause death, less cardiac death, and less CAV-related events compared to patients who remained on the calcineurin inhibitors. In this paper from last year, the patients who were converted to sirolimus had a significantly decreased risk of malignancy over time. And perhaps this is one of the things that contributes to the better outcome in addition to graft vasculopathy. So sirolimus reduces the progression of coronary allograft vasculopathy. It decreases the risk of malignancy. It's less nephrotoxic than calcineurin inhibitors, but it can cause or worsen proteinuria. This may be reversible, but the question is the proteinuria a marker or a predictor of patients who are going to have more progression of their coronary graft vasculopathy and poorer outcomes? Which brings us to the paper from today. So the aim of this paper was to look at the association of the development of proteinuria after the conversion to sirolimus on progression of coronary allograft vasculopathy and on outcomes of the recipients. There were 530 adult patients who underwent heart transplantation between 1994 and 2016. All received induction therapy, mostly with ATG, and then they were maintained on a 3-drug regimen of the calcineurin inhibitor, early cyclosporin, now tacrolimus, an antimetabolite, azathioprine or Cellcept, and prednisone. 314 were converted to sirolimus-based immunosuppression, that is sirolimus plus one of the antimetabolites and plus or minus some prednisone. 137 had the appropriate available baseline and 1-year urine protein levels, as well as intravascular ultrasound follow-up to be studied. And 36 of these patients developed sirolimus-related new proteinuria. The endpoints in the study were progression of coronary allograft vasculopathy by intravascular ultrasound, all-cause mortality, CAV-related events, and the combined endpoint of mortality and CAV-related events. A large number of baseline characteristics were collected and evaluated. So 26% of the patients developed new proteinuria or significant progression of proteinuria. And of those patients who developed proteinuria, they had at baseline, among those baseline characteristics, more baseline proteinuria, higher baseline creatinine and lower GFR, more hypertension, and higher hemoglobin A1C. Patients were considered acceptable for considering conversion to sirolimus or routine conversion to sirolimus if they were stable at least 3 months after heart transplantation, with no evidence of rejection and on low-dose prednisone. Proteinuria was defined as an increase in the urine protein level of at least 300 milligrams over 24 hours, 1 year after conversion to sirolimus. GFR was estimated and calculated based on the modified diet and renal disease and the combined chronic kidney disease epidemiology coalition equation. And surveillance was carried out for coronary allograft vasculopathy at the time of coronary angiography with IVUS. So these are the results. This is results of plaque volume, that is progression of coronary allograft vasculopathy. In the first column is the patients without proteinuria, and in the second column is the 26% of patients who developed proteinuria. And you can see in the second column, the patients with proteinuria had significant progression of their graft vasculopathy, plaque volume, vessel volume, and plaque index over time, compared to the patients without proteinuria that did not have significant progression of plaque volume, vessel volume, or plaque index. This is the same data in graphic format. The first on the left is the change in plaque volume over time, and that was greater among the patients with proteinuria. And on the right is change in plaque index, and again, significantly greater among the patients with proteinuria. In terms of patient outcome, the patients that developed proteinuria had a significantly higher increased risk of all-cause death over time. There was no difference in CAV-related events, and there was no statistically significant difference in the composite endpoint of all-cause death and CAV-related events, although there seems to be a trend toward worse outcome in this composite endpoint with proteinuria. This data was adjusted for recipient age, GFR, having had multi-organ transplant, and for the time from heart transplant to the conversion to sirolimus. So in conclusion, proteinuria developed in 26% of the patients after conversion to sirolimus. The patients who developed proteinuria had a worse baseline renal function and higher baseline 24-hour protein, but renal function and serum creatinine and GFR did not change significantly through follow-up. Proteinuria was associated with increased progression of coronary allograft vasculopathy and was also associated with increased all-cause mortality, but not CAV-related events. It's unknown whether discontinuation of the sirolimus and resumption of the calcineurin inhibitor would be indicated for those patients who developed proteinuria. The paper obviously has limitations and perhaps some strengths. The major limitation is this is an observational, retrospective, single-center, non-randomized design. And strengths might be the sample size and length of follow-up, that there was a standardized protocol for conversion to sirolimus, and that IVUS was routinely used for assessing coronary allograft vasculopathy progression. Again, I'm Rocky Daly, and thank you very much for participating and attending this journal club today and listening to me with this presentation. The moderator, again, Doug Jennings from Columbia, and the discussant, my colleague, Dr. Sudhir Kushwaha, who I thought would be excellent to provide better information than a surgeon over the very long-term care in these patients on sirolimus. Thanks again.
Thank you, everyone.
That was very good.
Thank you, Rocky, for that great presentation. Very succinct, very to the point. This paper is now open for discussion, so anyone in the audience who wants to put a question forth, please do so now. While everyone's organizing their thoughts, I guess there are several questions. I have quite a few I could ask, but one of the things that I just jumped to my mind while I was listening to your presentation is, do you, as the author and the discussant, have any ideas as to mechanistically why someone with more proteinuria would have such a more pronounced progression of CAV?
Well, CAV is a complicated process. There are many inputs to why CAV may occur, including the usual culprits as far as risk factors for coronary artery disease are concerned. So I think what we're seeing, so first of all, we're dealing with native kidneys, not transplanted kidneys. And many patients, particularly those with ischemic cardiomyopathy, come into transplant having had damage from years of vascular disease. I mean, coronary disease, ischemic cardiomyopathy is associated with vascular disease. So they come into worse renal function. And so I think that in itself sets up a vascular milieu which promotes vascular disease in general, and it progresses perhaps more rapidly in these patients. So following transplant, the patient is put on a calcineurin inhibitor. Now, just to backtrack, proteinuria, if you speak to renal colleagues, is really a marker of degree of renal injury. Forget about sirolimus. If you take people with ischemic heart disease or ischemic cardiomyopathy and compare them with dilated cardiomyopathy with normal coronary arteries, then we see that those patients have a greater degree of baseline proteinuria. So it's a marker of renal injury. When we give a calcineurin inhibitor, we give a vasoconstrictor. So we attenuate the degree of protein leakage, if you will, from these damaged kidneys, which have also been subject to cardiopulmonary bypass and the whole process of recovery from cardiac transplantation. So when we come to the time where we're going to convert the patient from a calcineurin inhibitor to sirolimus, it's like we're basically opening the floodgates. So we take away the vasoconstrictor, which is constricting blood flow to the kidneys and thereby limiting the degree of proteinuria. And in a sense, that kind of opens up, and we see an exaggerated proteinuric response in those patients. But the baseline issue is that they already have this milieu of poor diabetes, as evidenced by hemoglobin A1C, which has increased, pre-existing vascular disease, higher degree of lipids, worse renal function, which is associated with progression of vascular disease as well. So that kind of sets them up, I think, to accelerate their vasculopathy despite the attenuating influence of sirolimus. That was a very long-winded answer, but I hope it sort of gives some insight.
No, that was perfect. Thank you for that. I think that would be one of the main questions that we would have expected. At least that was something I was thinking as we were going through this. So I guess a follow-up that I imagine many of the listeners would like to know is, what is your protocol and process for conversion from a CNI to sirolimus? I think that's something that isn't necessarily well defined in the literature, so I would love to hear your insight on that.
Well, we typically wait, the very minimum, we wait around 3 months, as you said in the presentation. And then, but more typically, it's around 6 months. The reason for that is we try and minimize the steroids, and if possible, try and wean the steroids first. We don't want to do two things at the same time, which may affect rejection. So we will typically minimize the steroids, get to around 6 months, and then look at that patient in terms of are there any reasons why we wouldn't want to convert them? And most patients we put through this protocol where we will initially start a low dose of sirolimus, 1 milligram. We've used everolimus on a few occasions, but it's mostly sirolimus in our program. Just historically, it was the first agent available, and we've just gotten used to using it. So we'll start off with 1 milligram, and we won't really change the dose of the calcineurin inhibitor. Now, we know that calcineurin inhibitor levels typically go up with introducing sirolimus. So if the renal function is marginal to begin with, we'll try and come down by about 25% on the CNI dose, because that's about the level of increase which we see. And then we'll maintain that low dose, 1 milligram typically, for a couple of weeks, and then check levels of both. And depending on what the level is, we will make a further adjustment and eventually get the CNI down to about 50%. And then the patient will be on dual sirolimus and CNI for about a month or so. And at that point, we will recheck levels and then ramp up the sirolimus to a therapeutic dose, bring the CNI down to about 25% of what their baseline was, and then eventually, after 2 to 4 weeks, stop the calcineurin inhibitor altogether. When we first developed the protocol back in the early 2000s, we actually were extremely cautious. We had about a 20-week conversion protocol. Now it's down to about, I'd say, typically around 8 weeks, sometimes 6. Some patients have tolerability issues. They notice GI side effects, sometimes peripheral edema, sometimes mouth ulcers. When that happens, we will back off on the sirolimus and maintain lower levels for a longer period of time, because what we've observed is that usually most patients get used to the medication, and tolerate it much better. For instance, a big problem at the beginning was mouth sores, which can be very uncomfortable and difficult to treat. But actually, this is one of the easier problems we've had to deal with, because we usually back off, the mouth sores go away, and then when we go back up on the levels, the patient doesn't really get them back. There are one or two patients who I can think of who really were truly intolerant, but most patients tolerate it very well. GI side effects are another issue, and usually they improve as well. And the peripheral edema can also be problematic in some patients, but usually we can deal with that. So it's typically, a short answer to your question is it's around an 8-week conversion period with overlap. And the rationale for that is when we've spoken to immunologists here, is we're going from one immunosuppressive axis to another. So we're going from the calcineurin inhibitor pathway, which is how CNIs act, to the mTOR pathway. And so, in a sense, simplistically thinking about it, we don't want there to be some kind of rebound effect from withdrawal of a certain agent while we switch to the other agent, because the drugs act differently. And Rocky indicated a little bit in the early part of the presentation, but we've found that this lengthy overlap really prevents any kind of rejection, because some of the other studies and some of the trials which were attempted where they tried a much more rapid conversion resulted in treatable rejection. We've really not seen that in our patient population, and over the years we've looked at rejection rates in both groups several times, about 3 times actually, and not really seen any difference in overall rejection rates of treatable rejection as well as low-grade rejection.
Okay, that's excellent. Thank you for that level of detail. I think that was very thorough in terms of the strategy for switching and also touching on management of toxicities. Anyone who has managed these agents knows toxicities are very problematic. We struggle with this in our own practice here at Columbia. We use everolimus almost exclusively when we're doing an mTOR based regimen, and we do see significant toxicity associated with the side effects that you did manage. And then finally, you addressed the topic of rejection. There was a panel question that just came in that was asking about rejection, and I think you somewhat answered it with using your overlap to sort of mitigate the risk that can occur with CNI withdrawal. There is a question that just came in, and perhaps the pharmacist in me wants this question answered. Do you have a minimum threshold for your anti-metabolite dose prior to conversion, and would you convert someone who is unable to tolerate full dose MMF due to chronic leukopenia?
We typically at the start do not change the anti-metabolite dose. We don't make adjustments. So if the patient comes into it already somewhat with a tendency to leukopenia, suppose their white count is below 4 and they're only on 500 BID of CellCept, we typically wouldn't change the dose. We acknowledge that there is going to be a period of time where, in fact, the patient may be over-immunosuppressed and their white count may dip to the 2s. Usually, we just sort of hold on. We might reduce the CellCept a little bit further depending on what happens to the white count, but usually once the CNI has been withdrawn and they're on triple immunosuppression with sirolimus as the primary agent, the white cell count goes back to where it was, prior to conversion. But there may be like 3 to 4 or 5 weeks where the patient is more leukopenic, and we just kind of follow along really. And we haven't found it to be too much of an issue.
Okay. Thank you. That was excellent. I have question sort of going back to this topic of the proteinuria. So if this occurs, if patients develop significant proteinuria after conversion to sirolimus, what are the strategies that you use to manage this? Do you ever consider instituting ACE inhibitors? Do you reduce the dose? Do you just withdrawal and switch back to a CNI? Do you do something else? Do you switch into belatacept? So what's your strategy at Mayo?
It's an excellent question, and obviously we try and tailor to each individual patient, but use of ACE inhibitors or NRPs is one of the strategies we've used, and we've noticed particularly in the diabetic patients or the ones with an elevated A1C and poorly controlled diabetes, adding an ARB helps to mitigate the degree of proteinuria. And we talk about that in one of our older papers from the late 2000s. So it's one way to really deal with the proteinuria. Now, when the proteinuria gets into a nephrotic range, that's when there are problems, and that's when typically we'll get input from our renal colleagues, and our renal colleagues will sometimes recommending switching back to a CNI. And in those extreme situations, if it's greater than 3 to 5 grams over 24 hours, then and we really can't control it with an ACE inhibitor, then we may end up switching back to a CNI or greatly reducing the dose of sirolimus and introducing tacrolimus back, so they end up on quad immunosuppression if you include the steroids. There are very few patients who become truly nephrotic. If it stays below a gram over 24 hours, we consider that tolerable. Now, one of the reasons for proteinuria, I said earlier on in the discussion, is because the vasoconstrictor effect of CNIs is removed. So the kidneys are just filtering more blood at a more rapid rate and thereby leaking more protein. And the ACE inhibitors or ARBs have the same effect of constricting down on those vessels. So they will help the proteinuria, sometimes at the price of a more elevated creatinine, though.
Great, thank you. I think you touched on this, but just for clarity, one of the audience members asked if you withdraw steroids on someone who's on sirolimus and no longer taking a CNI. So I think they're asking, do you cut down to just dual therapy with sirolimus and MMF? I think you had said yes.
Yeah, we've got a bunch of patients who are just on dual therapy with sirolimus and MMF. And yes, our strategy is to try and withdraw steroids on all our patients. There are some patients who we can't because they're either recurrent rejectors or they've had an episode of AMR, and we're more cautious about those patients. But yeah, we have a significant number of patients who are just maintained on sirolimus and MMF, and that combination usually works pretty well. We don't see any more rejection compared to CNI plus MMF as dual immunosuppression.
Excellent. Thank you. We have a question. I think the audience member is asking, why wasn't proteinuria progression assessed sooner than 1 year? I think that's referring to your methods in the paper.
Well, I think it is the 1 year is the sort of annual evaluation studies, and so at our we have a baseline set of studies we do at around 6 to 8 weeks, and typically we haven't been doing a 24-hour urine protein in those patients as part of that protocol. At the 1 year annual evaluation, 24-hour urine collection is one of the mandatory studies which we do as part of that 1-year process, and that's why that's sort of a consistent number. Some of those patients, we may have gotten a 24-hour urine collection if they're having renal issues and they've seen one of our nephrologists and they've wanted that as a baseline, but that's the reason for that. It's really more to do with our follow-up protocol more than anything else. I suppose it makes sense for us to try and get a baseline urine collection not too long after transplant, but we're making so many adjustments at that time, and typically at that early time point, the patient is on a calcineurin inhibitor anyway as baseline immunosuppression.
Very good. Thank you. So a question that I was thinking that someone else in the audience also touched on, I'm going to kind of combine these two questions into one. Is there a patient phenotype that you would not consider for conversion to a mTOR-based regimen, either due to their baseline renal dysfunction, high levels of protein, like a creatinine or proteinuria threshold that would cause you to pause, or perhaps someone with an immunologic profile associated with their risk of rejection that would cause you to potentially not convert?
Yeah, that's a good question. In terms of the immunologic risk profile, we have had, like many other centers, a handful of patients who have presented with what seems to be an antibody-mediated rejection type of process. And in those patients, we are a lot more cautious in even withdrawing steroids. And what we end up doing in those recurrent cases of rejection, in fact, we were just having a group discussion earlier last week about a patient of ours who has had previous severe fungal infection of the lungs, which he recovered from. And at that time, sirolimus was withdrawn because of the issue with sirolimus and potential lung toxicity. And I'll get to that in a moment. But then they've presented with evidence of recurrent AMR on calcineurin inhibitor plus MMF plus steroids. And in that patient where we've been discussing adding sirolimus back, so they're on quad immunosuppression because of their recurrent AMR. In terms of patients we would avoid exposing to sirolimus, if there's prior lung injury or some pathologic lung process, then I think the patient is more predisposed to sirolimus lung toxicity. So we've had a couple of patients who have had previous lung injury. One patient with a history of COPD, which was relatively bad. He was a marginal transplant candidate. We transplanted him anyway. Because of renal dysfunction, we attempted a conversion to sirolimus, and he ended up with sirolimus lung toxicity, which resolved following withdrawal of the drug and switching back to tacro. So if there's any degree of previous lung injury, we would really question whether or not to subject that patient to the risk of conversion. Most of the patients have acceptable pulmonary function. In terms of renal dysfunction, it's a mixed kind of bag, in the sense that our nephrologists, like nephrologists worldwide, do not like proteinuria. You know, they see it as a very bad thing, although I've never had a completely clear answer as to why they see it as so bad. But, you know, there's no doubt that the proteinuria, the amount of protein in the urine goes up, but I think it's a judgment call. I think if the patient is already leaking 2 to 3 grams of protein on a calcineurin inhibitor, then I think we have to be very cautious about saying, okay, we're going to convert this patient, because we know that the degree of protein is going to, the degree of proteinuria is going to increase. So I hope that answers your question. So in short, people with pre-existing high level of proteinuria, we'd be very cautious about, and people with a history of lung problems or lung injury, we'd be very cautious about.
Okay, great. Thank you for that. Another question from the audience. Have you ever used sirolimus monotherapy in patients with infections or malignancies, or have you used mTOR inhibitor along with low-dose prednisone as an alternative regimen?
Yes, we have. We've got a couple of patients who have had PTLD, in whom we have switched to sirolimus, and in whom the other immunosuppressives have been withdrawn or minimized. I mean, one of the, as Rocky showed some data from our malignancy paper, overall rates of PTLD and all cancers, actually, including squamous cell, are markedly reduced in a sirolimus cohort. And it makes sense. I mean, most cancers, particularly PTLD, are highly proliferative, the proliferation being driven by the cell cycle. And of course, sirolimus is a powerful cell cycle inhibitor, which ends up decreasing degree of proliferation. And so it makes sense that it decreases cancer rates. Having had some patients who have developed cancer relatively early on, including a couple who developed PTLD even within the first 6 months, we've targeted them for a more rapid conversion to sirolimus, and then really scaling back on everything else to minimize immunosuppression, which is typically what we do for management of malignancy. And those patients have done okay, and they haven't had any cardiac rejection. There's a lady I saw in clinic who's about 6 or 7 years out. She has a PTLD. She is on sirolimus monotherapy. We always expect when we check the echo that there's a decrease in LV function, cardiac function, but everything's been fine. And the biopsies we've done on her have been negative for rejection. So I think it's feasible. It's a powerful enough immunosuppressive, but obviously we're not advocates of monotherapy, you know, either Tacro or Siro for that matter, unless there's a cancer history and development of PTLD.
Well, that's very interesting, because I don't know that I would ever be able to convince my providers here to go to sirolimus as monotherapy. So I'll have to keep that in my mind when we're next facing one of these patients.
Yeah.
So the interesting question that just came up is, is there any preference between different mTOR inhibitors in your center? I think I know your answer, sirolimus versus everolimus, but perhaps if you could explain your rationale and your thoughts for that.
Yeah, I mean, we have just historically used sirolimus. We've gotten to really have a level of familiarity with all our providers, our transplant coordinators, our pharmacy people. And so as a result, and because it was the time we started using it, everolimus wasn't available. Everolimus came along maybe about 10 years ago or so, if I'm not mistaken. And so we haven't really had any impetus to switch it. There's a handful of patients who we've switched because we thought it might be better tolerated, and we thought that they'd be better off on everolimus. But so really, it's nothing to do with preference of one agent over the other. It's really a historical thing, and there's no reason why we wouldn't necessarily use everolimus. It's the same drug. It's just one step down. It's rapamycin derivative, basically. If you look at the pathway, it's just one step down the pathway, and it's everolimus is, from my understanding, allegedly better tolerated, although I can't say we have the institutional experience to support that statement. But it's what we read and what we hear about. But so I'm not averse to using it, but we typically just go with what we're familiar with, and a large part of a good medical practice is having familiarity with the agents you use. So we have all this sort of historical information and background, and that's really the reason for it.
Yeah, I think it seems to just be a matter of preference and comfort, because we almost exclusively use everolimus here at Columbia, and I think that's just because of the way it's always been. I feel like this question comes up at the ISHLT every year as to whether there is an appreciable difference in the pharmacology of these agents. So obviously the data is largely based in everolimus for the randomized trials, and I've never had an answer that I found particularly compelling related to that point. I suppose what the prevailing thoughts are here at Columbia is that there's a perception here of more lung injury with sirolimus versus everolimus. This is obviously anecdotal, so I don't honestly know if there's any truth to that in our internal data. I don't think it's ever been evaluated. I guess if there's one obvious answer I could point out is that everolimus is twice daily and sirolimus is a once daily drug. And there have been patients in whom we've had issues with compliance, and we've switched them to a daily regimen of usually, if the CNI is withheld, something like Envarsus or Astagraph once a day, Tacro with once a day sirolimus. It's just something we've tried in people who have really difficult time taking a twice daily med. Honestly, other than that, I can't think of any other difference.
Yeah. No, I agree with you.
Okay, I'm perusing through all the questions that have come in. There was one. This was related to something we discussed earlier at the beginning of the journal club. Does sirolimus have direct renal tubular toxicity? And the follow-up is, are there any data available about patients with combined heart-kidney transplant? And I'm assuming that means like sirolimus with heart-kidney transplant.
Well, there isn't a lot of data in that group. We have done a fair amount of multi-organ transplants, heart, kidneys, and obviously, as I alluded to earlier in the discussion, we're dealing predominantly in our cohort predominantly with patients who have native kidneys, and the transplanted kidney is obviously different in the sense that it's subject to immune assault for the same reasons the transplanted heart is subject to immune assault, whereas the native kidney in somebody who's received a heart transplant doesn't get immune-mediated damage, but suffers really from the side effects or the effects of the agents we're using. And so that's the difference. Now, I know that when we are dealing with our combined organ patient population, we work very closely with our renal transplant colleagues. And each conversion in that group is really after a lot of discussion, because the renal colleagues don't like the proteinuria. It's not clear to me, and I'm open to listening to what anybody else may have to say on this subject, but it's not clear to me whether transplanted kidneys have a greater propensity to leak more protein than native kidneys. And so that may be one reason why our renal colleagues don't use a lot of sirolimus, and if possible, they prefer to leave the patients on tacrolimus. Having said that, we've certainly got a number of combined organ transplant recipients who are doing perfectly okay on a 2-drug regimen with sirolimus and Cellcept, and sometimes a low dose of prednisone, which also our renal transplant program prefers. So I don't know if that answers the question, but that's really our experience. We haven't really carefully looked at that, I have to confess.
Yes, that does. I would have to concur. We have a fairly decent size of heart kidney patients here, and I haven't seen one that was converted for that regimen, probably for similar reasons. Question I came in a little earlier about you were talking about your protocol, and so an audience member has a question. How soon do you re-challenge higher sirolimus after an adverse event, such as the mouth sores? Is it once they're resolved, or is there a more like set period of time?
No, it's really once they're resolved. We work carefully with our transplant coordinators who are in touch with the patients, and so we will back off on the dose. We'll wait for resolution of the side effect, and then we'll go back up slowly and see if they recur. And most of the time, when it comes to mouth sores, they don't recur. And most patients who are on chronic therapy don't describe that as a problem. It's certainly an irritating problem at the beginning when we're first exposing them to the medication in a certain number of patients who seem to be more prone. There are other patients who never get a mouth sore, actually.
Yes, I think I agree. We've seen some patients that have terrible side effects that we can't manage, whereas other patients have very little side effects, if any. Great. So I'm not seeing any more questions from the audience, and I think I've asked all the questions that I had. Do either of the presenters / discussants on the paper have any closing thoughts?
Rocky, do you want to say a few words? I don't know if Rocky is still there.
He's on mute right now, so please go ahead, Dr. Kushwaha, if you would like to say a few words.
What I would say is that we have had a lot of success using this approach of sirolimus as primary immunosuppression. I think that the theoretical advantage of attenuation of vasculopathy, as well as attenuation of malignancy, really, from our perspective, benefits outweigh the risks, which I think are relatively minimal. And I think when I speak to members of the transplant community at various meetings, the question comes up, well, patients can't tolerate the medication. I would say that it just comes down to how the conversion is undertaken and whether sort of tailor the conversion. I really don't advocate converting quickly, but we've demonstrated not only is it feasible, but it's got several advantages, and we're big proponents for that reason. So those are my concluding remarks. I think the paper is an interesting observational paper in the sense that the proteinuria we're seeing is really a marker for all the other risk factors which can affect patient outcome and pre-existing risk factors coming into transplant.
Dr. Daly is with us again. Dr. Daly, if you had any closing thoughts.
Well, nothing to exceed what we've heard in the discussion. That was a really interesting discussion, and thank you very much to Dr. Jennings and Dr. Kushwaha for the insightful questions and insightful comments in managing these patients. I think this is an underutilized, clearly from the ISHLT data, underutilized arm of therapy, at least if we look across the US and maybe across the world. And this has been really very interesting here today. So thank you to both of you.
Well, thanks, Rocky, for presenting it. It was a great presentation, and I enjoyed participating in the discussion.
Dr. Jennings, if you had any closing words, please feel free. Otherwise, I will take it away with our administrative close.
I guess I would like to again echo sentiments and express my gratitude to Doctors Kushwaha and Daly for this. This was a great discussion, fascinating topic. mTOR inhibitors are near and dear to my heart. And I think the proteinuria that's associated with them it's a very salient discussion. So also just thank all the attendees. We had a nice, robust attendance today. So thank you everyone for taking the time out of your day to listen to this presentation.
The American Society of Transplantation would like to echo Dr. Jennings' thoughts. We would like to thank our moderator, Dr. Jennings, our discussant, Dr. Kushwaha, and our presenter, Dr. Daly, and to all of our attendees for today's excellent session. Please remember to complete the evaluation survey and visit myast.org/journal club to view the video archive and register for upcoming journal clubs. To learn more about AST's Thoracic and Critical Care Community of Practice and the TxPharm Community of Practice, please visit myast.org/COPS or connect to the COP hubs.